And we are going to have a symposium mixing and bringing together, more than mixing, bringing together two realities, the reality of the mitral and of the tricuspid interventions, which is already the case for years in the field of surgery, but now we are at the very point to reach the same goal with transcatheter intervention. So the first part of the symposium will be dedicated to the Edwards Cardioband in the mitral position. You know, experience is accumulating. We have more data. They will be shown to us. Then you learn about the echo guidance, which is very, very important in this procedure, as well as in others. And Dr. Latib will tell you it's not that difficult to learn, which is a very important point. And after a group discussion, we'll move to tricuspid. Absolutely a new field. But it's very important for us to learn if this device, which really mimics the best surgical technique, fulfill the requirements and fulfill our expectations. And we are going to listen about the first experience and, more importantly, probably see a very nice case from Georg. So now it's my pleasure to ask the first speaker, who is, you know, an hybrid, but here he will behave correctly and behave like an interventionist and tell us about one of his babies. It is the Edwards Cardioband system for mitral regurg. So, Francesco.
So I will talk about the first baby who's going to high school now, or maybe university.
I know your baby, the terrible one with the gun, huh?
Yeah.
Yeah,
So the topic is obviously very well known. We talk about heart failure patients. The heart failure community is ready to open the door to mitral valve treatments, and we're talking today about Cardioband, which is an angioplasty device, and in my opinion, the device which will change the perspective of heart failure treatment with functional mitral regurgitation. As a matter of fact, as a surgeon, I have to admit that surgery has not been solving the problem. The invasivity and the consequences of a open heart solution have not been so successful in this field, and we have seen several attempts to show benefit of valve repair in functional MR, which have been failing, and as a matter of fact, a lot of patients are untreated. So we need another solution. There are other solutions which have been attempted and somehow successful still in the process, mainly MitraClip. But what we give us the perspective now today, Cardioband is the most commonly performed surgical procedure which now can be performed through a catheter. How this can be done? So this is an animation of the procedure. It is a transfemoral transseptal approach using a sophisticated delivery system which allow navigation through all the left atrium and allow the delivery of this dacron band, which is fixated into position with multiple anchors. Each individual anchor is fixated by guidance of echo and fluoro, and the process is repeated multiple times so that the band is implanted from the anterolateral commissure towards the posteromedial commissure. Again, all this is repeated, all the same maneuvers. It is probably a little bit longer than a quick shot MitraClip today, but in principle, in experience sense, it is a procedure which can be done repeatedly in less than 2 hours, still less than a surgical procedure. Again, on beating heart. What is the great advantage of this compared to surgery is that this ring, which looks like a surgical ring, can be then restricted to reduce the annular size according to the echo guidance. So there is a adjustment of annular reduction according to physiologic conditions. And this probably has an important consequence also on the efficacy of this particular device that I'll show you now soon in the results. So what are the advantages of this approach is that obviously it is a transeptal access. There are other technologies for repairing the annulus which are not transeptal. This is one of the few. It is a fixation on the supraannular position which preserves the apparatus. It is consistently reducing the annular dimensions 30%, and more important than anything else, it leaves a very small footprint that opens the perspective for additional procedures in the future. This device has been tested in a CMAR trial, which has been designed to evaluate performance and safety of the deliveries of this device in the field of functional mitral regurgitation. The inclusion criteria were classical for functional MR patients, and the exclusion criteria are also classical for this kind of procedures, this kind of trials. Mainly, the main exclusion have been calcification of the annulus and obviously presence of degenerative lesions. The primary endpoint has been safety in terms of rate of major serious adverse events, and performance in terms of ability of implanting the device and ability of reducing mitral regurgitation. There were also a number of secondary endpoints. These are the sites which have been participating, and this is the data which is available on 60 patients, about 60 patients in a full analysis set. You see here patients, typical patients for functional mitral regurgitation with a average ejection fraction of 30%, number of comorbidities. The safety of this procedure has been shown pretty well by low rate of complications. Unfortunately, there have been two deaths somehow unrelated to the procedure itself. But more importantly, there has been a tremendous improvement of mitral regurgitation, which stays constant over time. And this is the first time that we present this data, which are paired analysis on 36 patients, showing that at 12 months, the majority of patients have no or minimal MR, so about 60% or more of patients have really trivial or no MR, according to core lab. This is because this device allows a septal-lateral dimension reduction, which stays over time, which is unique in this field, and there is no other device that can achieve this outcome. Obviously, this is associated with improvement of symptoms, improvement of functionality of these patients, and therefore, this device will play an important role in the future of functional mitral regurgitation treatment. I think the ideal landscape of this procedure is that it delivers such a minimal footprint that it is ideally designed for earlier treatment, which is at the end of the day the holy grail of functional MR treatment in functional MR. So in summary, transcatheter mitral valve repair using a catheter with the Cardioband Edwards system is feasible and safe. There is a significant and consistent reduction of mitral regurgitation in most patients. There is abolition of mitral regurgitation. This is linked to a significant and consistent reduction in septal-lateral dimension, preserving future options. Obviously, more studies are needed to expand indications, but I think this is one of the most important innovations in the field, and we will benefit from this in the next few years. Thank you.
Thank you very much, Francesco. The next presentation on echo guidance of the Cardioband procedure will be given by Dr. van der Leben from Germany.
Thank you very much. We'll now put an emphasis on the imaging guidance in the Edwards Cardioband mitral system. If we look through the different steps of this procedure that you've seen in concept by the first talk by Francesco Mazzano, it involves a venous puncture. You need no imaging for that, that is certain. But then the transeptal puncture, which is CT pre-planned, is echo-guided. The transeptal sheath positioning, the guide catheter positioning near the LAA in the primary landing zone at the hinge point, The guide catheter and repetitive anchor positioning for 14 to 17 anchors is done with echo and multiplanar reconstruction. And at the end, we check, of course, for the chinching effect and the mitral regurgitation assessment after the procedure. So we've seen in the first graphical comic already the different steps. They can be subdivided into these 4 steps: the transeptal puncture, the system insertion, implant deployment, and then the chinching with the size adjustment tool. So I'll present you this with a patient case. You see there's an extremely enlarged left atrium with a length of about 12 centimeters. This is more than 300 cc. You can appreciate that there is a massive reflux into the right pulmonary veins in this patient, and a typical functional MR with reduced LV function and large atrium. The first step in order to be able to reach with the system all different parts of the ring is a thorough transeptal puncture. This puncture is CT pre-planned, and as you see, you will then get a height information coming down from the superior caval vein. You'll get an anterior-posterior orientation, so you measure the distance to the aorta, and you also measure the height to the mitral valve in a 0-degree 4-chamber view. This is summarized in these images. You then put your system through the septum, and the further steering is then done with a hooked sheath, as you can see here, a steerable sheath which has 24 French. The first step is to reach the hinge point of the valve. As you can see nicely here, we're above almost the anterior leaflet next to the left atrial appendage here on the side. It's a surgical view, so at 12 o'clock is the aorta. You then have to make sure that you're in a landing zone. As you see here, this is an example where the catheter is a little bit too much into the valve, so he reaches the leaflet. You can, of course, control this by repetitive angulations in 2-dimensional echo, but I'll show you another technique that is much easier and enables a faster procedure. Through this procedure, the different angulations of the anchors are being controlled, and you can nicely see that these are parallelized according in a fan-like shape to the posterior annulus of the mitral valve. So the first step is to include 3-dimensional imaging into the procedure, and we have a surrogate virtual surgical view in this procedure. Now on the right-hand side, you see at 12 o'clock the aorta with the left sinus, and at 9 o'clock you can see the left atrial appendage, and you start at the surgical hinge point actually with this procedure, following through segment 1, 2, and 3 till the septum to deploy all different anchors. So the first improvement after the first 20 or 30 implants was to include a multiplanar reconstruction, which is also called flexi-slice, in order to derive from the 3D data set the exact angulation of the catheter at each point, and also to identify the vessels. As you can see here in the upper right, you can nicely see a coronary sinus, and you are also able to see the circumflex artery in these different levels. This is also depicted here, but what you can also see is that we're able to see the metal anchors in the annulus themselves. So you can see the angulation and the angles in both the 3-dimensional data set as well as in the derived 2-dimensional cut plane, which are simultaneous recordings. This is then done until the hooking position on the septal part, where you have to invert the catheter to come back 360 degrees in order to finalize the implants at the site of the medial hinge point. This is the result after the implantation of the ring. You can nicely see it's now then being detached and chinged to a position where you decrease both the intercommissural diameter and the AP, or surgically septal lateral diameter, as depicted in the first talk. So this is the natural valve on the left-hand side, the band deployed, and the band chinged on the right-hand side. One of the advantages of this system is that all further options are kept open, and using an annuloplasty, of course, you generate no stenoses. You see here that we have a mean gradient of 1.4 millimeters mercury after successful reduction of the mitral regurgitation, and you see in this large atrium, and you can see that there's a trace left regurgitation after the procedure. It's the same patient that you've seen before. So to come to a conclusion, the heart implant team, there is an important communication between the interventional cardiologist and the interventional echocardiographer. Both 3D echo with MPR flexi slides, as I've shown you, and fluoroscopy is needed to allow for direct virtual control of the anchors. And the imaging guidance allows you to also control the angulation itself. Chinching effect at the end and gradients are controlled under normal hemodynamic conditions. Thank you very much for your attention.
So thank you, Stefan. So you saw the device, very nice, very sophisticated. You saw the echo guidance, very nice, very sophisticated. But we have to listen now. Azim, who is going to tell us how we can learn and how quickly we can learn and try to master this procedure.
Great, thank you, Alec. It's a real pleasure to be here and talk about how quickly you can master Cardioband. I guess I keep getting asked to talk about this, about how you master Cardioband, because when you first see the procedure, it may seem fairly complex and difficult, particularly for people who haven't done transcatheter mitral interventions. But what I want to convince you by the end of this is that for a procedure to be learnable and teachable, it needs to be reproducible. And I think the device is very reproducible in its movements and how you use the device. And certainly, this was one of the first transcatheter mitral interventions I learned. I work in a center where the first in man was done, and where we've been exposed to a number of different transcatheter mitral approaches. And really, this was one of the first that I learned myself. And I've noticed, I've done about 18 cases now as a first operator, and I really noticed how my time for the procedure has really decreased. You know, I did a procedure not too long ago where it took me 60 minutes to put 16 of the anchors in, which I think is a really respectable time to do such a procedure. And if the procedure is effective, it makes a lot of sense. So how's it possible? How can you learn this procedure? Because that's what you're asking yourself. You're sitting here going, well, the results are great. My patients probably do need annuloplasty because edge-to-edge doesn't completely resolve the problems, and can I learn this? Well, I think you can, because learning, it comes with training first. And so there's a really excellent training program. And what the guys from Cardioband did was develop this simulator. You know, now with simulators, we can do a procedure without ever hurting an animal or doing it on animals, and do the procedure similar as it would be in the human, right? So what do we do when we do this procedure in a human? We do it under fluoroscopy, and we use TE. So if you look here, what we're doing, here's the simulator. It has moving leaflets in it, okay? The catheter is coming in here. It's under the fluoroscopy table. You have your two projections, because you do this procedure in two angiographic projections, so an en face and a perpendicular view. And you see on the other end the TE probe coming in. So you, along with your echocardiographer, the team who does the procedure, train on a simulator. Is it realistic? Well, I think it is pretty realistic. So here's a fluoroscopy. You can see on the side. You can see yourself putting those anchors in as you do it. But even more useful is you can get TE. You can get actual 3D echo. And the fact that the leaflets are moving, you can see where the hinge point is. And so you can practice the procedure before you do it. So when I did my first procedures in human, I got the team to come around, and the day before we practiced, and I did it over and over and over again. And I could do it as many times as I wanted to, because it's a simulator. And I did that the first few times, not just the first procedure I did, to kind of learn the movements, understand what is it I needed to see when I was looking at the echo and looking at the fluoroscopy. And here you see an implant implanted, looks like it's on the human, but it's done on fluoroscopy, and it's done with echo imaging, but on a simulator. The bonus is I can then take it out and look at it and actually see what I've done, okay, which you can't do in the human. So this is another added advantage. And the reason I think this is really learnable is because it's reproducible. So when I first started learning Cardioband, I said to them, and someone's learning to be a pilot, he can open a book and he can look at every single step. Okay, it's really reproducible. Taking off on a plane is reproducible. It's the same steps you do every single time. So other than the simulator, I also wanted to know on each part of the annulus, what would I have to do? And so what they've done is broken it up. So when you're in P1 and you're near the trigone and you need to move along P1, they're reproducible steps you'll do every single time. So in about 90% of cases, you do the same steps over and over again. There will be cases where, because of retraction of the leaflet, because of the shape of the anatomy, where you did your transeptal puncture, you may need to change that. But in most cases, you have what an airline pilot has. He has a book. It's his playbook that says step for step, this is what you have to do. This is the part of the catheter you turn in order to get from point A to point B. And so you can do that, and you have this chart. And I actually had this chart pinned up while I was doing the case to remind myself, even though I had a proctor there, to remind myself exactly the steps I needed to do. And so that gives me to the third part, the proctor. So we had, when we did these cases, we had a non-physician proctor help us, and it was really useful because they see all the procedures, they do a lot of procedures, and this was really useful in showing us how to move around the annulus. Success comes from training, but I think it also comes from planning. And so one of the things that when you go into a Cardioband procedure is, and I think this distinguishes really Cardioband from other mitral repair procedures, is that you are pretty prepared. Using CT, we know where to do the transeptal puncture. We can actually decide on the size of the annulus band you're going to implant. But you can also see, and it's worked out, exactly what the catheter will look like in different projections. So you know when you're in P1 or P2, if you're having difficulty, you have pictures already of what your catheter is supposed to look like in your two views. So you can really go to that and understand that. Imaging, you've seen enough. It's been really useful, and particularly the multiplane. And I think more than anything else, I'll show you one of my last cases, since I've almost run out of time, which is this one. This is a patient I thought was a good case for Cardioband, annular dilatation, a large jet along the entire coaptation band. You can see that there. I put in 15 anchors, and as I cinched, you started seeing smoke already. So we're really being effective. There was still some residual MR, but as you get confidence with this device, you can decide that even residual mild MR is no longer good enough. And so we cinched even more and went to maximal cinching, and there's really no MR. And so in patients with annular dilatation, as their main mechanism, you really can obliterate the MR and get a surgical-like result. So I'll really conclude. I think you can learn how to do Cardioband. I think the training program is extensive and will get you up to speed. It's very practical as well. The device is really usable. The navigation is predictable. It's reproducible. And reproducibility, I think, leads to better outcomes and making a procedure teachable and learnable. Thank you for your attention.
Now, let's start by discussing the first part, the Edwards Cardioband system in mitral regurgitation. So, firstly, who has any experience in the room with this device in mitral position? Okay, so 0 hands. That's a good start.
You can
it's
improve.
A very good start. When you do a randomized study, you should choose a good control group. So now, I would like to ask you, Francesco, you are the father, and also Karl-Heinz and Georg have a very large experience of the device. So, in your opinion, who is the best candidate for this procedure?
So in my opinion, the best candidate is obviously a patient who has annular dilatation as a main component of mitral regurgitation. You should avoid in the very early stage to treat patients with severe tethering because not all of them respond, although I would say some of them even against the law of what we learn in surgery, some of them respond well to this therapy. And to select the ideal patient to start with are the ones who have a very large atrium. They have a beautiful echo guidance, echo imaging. So this is the ideal patient to start your practice. As I think about this procedure, the way we design this procedure has not been to palliate. So this is a procedure which has been designed to replace surgery for functional MR and potentially replace surgery also in other fields because this is delivering surgery to a catheter. So the ideal patient will be in the future will be all patients who require repair.
You don't replace the tool, you replace the approach.
I replace the surgeon.
No. Hey, take care, because he's both.
No.
This guy is biased, huh?
No.
Okay.
But I rephrase what Cybercar says all the times. You know, when people say that you should replace the valve, you should probably replace the surgeon. So I think in this field,
Wow.
I'm pretty sure that this will be the case also for transcatheter mitral valve interventions. A lot of interventionists will love to do replacement. Will be easy, maybe, I don't know. I'm not sure will be as safe. A community of experts in repair will be leading the field. So if you really want to lead the field, learn the repair. Forget about replacement. Replacement will be part of your armamentarium, but repair will make you different.
So, excellent answer. It goes far beyond the question, but excellent answer. Now let's come back to Earth, and I would like to ask the same question, if you remember the question. Who is the best candidate? Karl-Heinz.
You know, I mean, when we started this program, of course, we were also looking what we thought is the ideal candidate. And that is very much what Francesco described. Of course, a large annulus and not too much of tethering and a spherical enlargement of the LV. However, the issue is, and therefore it's for me so difficult to answer that question, that as Francesco showed, even if you look into smaller annuli, and if you look into severe tethering, you also have very nice responders. So I think at this point in time, for me, the inclusion of a patient into the Cardioband program is when it's technically feasible. So if I can do it, I do it. And as Francesco stressed, it doesn't prevent you from any further intervention. So even over time, if there is continuous remodeling of the LV, and with this significant more tethering, you get back into MR, you can clip the patient. And we have done a couple of cases, I think all of us, with a second procedure, and you can even do a valve implantation at the end of the day. So at this point, I think if a patient is technically feasible, if it can be done, I would always start doing the case, and we still have to learn beyond surgery what is the right dimension of the LV, what is the right angle of tethering, what is the right annulus size. And I think the numbers will be completely different what we have learned so far from surgery. So I'm very open-minded, and I do whatever I can do. And I think that's the message at least from my learning, that we cannot exclude a good response in even a patient where we might consider him not to be the perfect case.
Okay. If I may jump on your remark, because you said that we can go probably beyond the criteria which are usually used for surgical annuloplasty. Do you think it's true?
So one somehow unexpected outcome is what I've shown you in terms of reduction of MR over time. This data overrule surgery. If you look at the randomized data from the CTS trial, these data are better than what you see after surgery. What is the reason for that? There are at least two reasons. Number one, you implant this ring better than surgeons. I only can tell you because I'm a surgeon, and I know here I see that my screw goes in the ventricle. I put each screw in the base of the left ventricle. In surgery, I don't see where is the left ventricle. I just see the endocardium of the left atrium, right?
Really?
Sure.
Oh, disappointing, huh?
Second, so fixation is very solid here, and it targets the base of the ventricle. Number two, in surgery, I guess what kind of ring I have to implant. Here, I adjust on beating heart. And you know, there has been some cases where we have been doing the opposite of what Azim has shown. Sometimes it's good to cinch more, sometimes it's good to cinch less, because if you cinch too much, you may have frozen leaflet. Now, having this possibility of adjusting online makes this, to me, this is surgery 2.0. I mean, it's better than surgery.
So maybe, Francesco, maybe I can comment to that,
please.
because we had a similar case, and I think we should be challenging. You know, there's those predictors of failed annuloplasty or recurrent MR. We should be challenging that based on that fact. You know, we've had a case with asymmetric tethering, which should have not worked, and it was interesting as we sort of got to 3.5 of cinching 4, the MR decreased. Okay, there was still some MR, but when we cinched even more, the MR increased again. And so we were able then to go back to the result we had before. So I think we're going to challenge a lot of those predictors of failure in the future, because you can adjust and you can go back as well.
Okay, I'm sorry, I forgot my friend Ralph. So Ralph, no, I don't forget, never forget you. Do you want to comment any more on who is the most appropriate patient for this procedure? So you stay, okay.
I think it was all mentioned, but I would add to Asim that I think the ring is softer on the medial part to the septum. So one of the advantages that we haven't addressed yet is that we bring the same tension to the wire, but the tissue will react differently. So if you really look into the sequential fluoroscopies at cinching, you will see that the anchor distance decreases separately. And I think this is a huge advantage of such an implanted ring. We have the same distance in the beginning. We put the same pressure to all the distances between the anchors, but the softest region that dilates first will also be cinched first. So I think this is another idea why also it may work in asymmetric tethering.
Now I'd like to ask Georg, because we were together, I don't remember where, but what is your explanation of the results we have, which may look even better than the surgical annuloplasty? You were very cautious last time. It was German Society of Cardiology. Maybe you were, cautious there.
Yeah. I'm trying to. First of all, I'm going to stay cautious. Maybe a word of caution. We have implanted 60 patients or something, maybe a bit more than 100 patients, so I wouldn't compare it to surgery right now. The data are extremely encouraging, and I'm a believer of the technique, so I'm not suspicious, but still we have to learn more about this technique. So far it looks really, really encouraging, but we cannot right now state that we are already better than surgeons. I would love to state this. So why are the data so encouraging? I think Francesco mentioned it already. We can adjust in real time on beating heart, so we know exactly what we are doing. The surgeon is off pump, is on pump during fixing the ring to the annulus, and then he has to refill, and he looks at the regurg after putting water into the left ventricle. So it's a pretty artificial system. So he has to guess quite a bit. That is one major issue. Another issue is patient selection. I mean, we also were very cautious in the patient selection within this trial so far, which we have to be, because we have to control the situation up front. It's about feasibility so far. So these are two major issues. And another issue is if you talk about asymmetrical patients, so the typical ischemic heart mitral regurgitation patient, we may also end up with some issues if we have severe tethering on the posterior mitral leaflet. So we have to sort this out in future studies.
Okay, so you have another remark on this?
Yeah,
one?
just maybe a short add-on. If you look into the data analysis that the core lab Paul Graben has done, and if you look into the ischemic patient population, then something you can observe what has been described by Dr. van Bardeleben, that particularly the P3, P2 segment, which is mostly affected, moves more forward, and thereby is really compensating for the defect that was causing the mitral regurgitation. So you have some kind of an eccentric effect of the band, which is something you don't see if you have a stiff ring that you implant. So I think that this system really can adapt in some way to the individual anatomy of a patient, which probably gives you the better effect beyond what has been described already in comparison to surgery.
Okay, thank you. And now, at the end of your slide, I think you said, well, one of the beauty of this device is that it leaves the options open for the future. So you open the door to the combo. Can you give us your thoughts about the combo combination?
So combination of therapies is going to be probably one way of solving problems in transcatheter mitrals. Obviously, we have had all the experience of failed procedures in both directions. We have had Cardioband patients failing and treated successfully with leaflet repair, and the opposite. You have seen leaflet repair mitral clip cases failing, which we have been treating with Cardioband effectively. In surgery, there is we built this experience in functional MR that adding leaflet repair and annuloplasty is a real strong solution for functional MR. The freedom from recurrence of MR is amazing. So combining the two procedures is, why does it work? Because you basically act on the two components. The component of annular dilatation is treated by the annuloplasty. The component of tethering is treated by the leaflet apposition. In this area where the leaflet don't touch each other, you force the coaptation. And this is enough when in combination with ring annuloplasty to improve results.
So may I ask to Georg and Karl-Heinz and Ralph, in Germany, you can do that. You can do some combination. Can you tell us in which patient are you using this combination for this preliminary experience?
Yeah, I mean, again, it's a preliminary experience. First of all, what technique would I use first? I would first go for a Cardioband procedure in a patient where the leading pathology is, of course, annular dilation. And then if that patient has not a completely reduced MR and maybe has a part prolapse and also long-running DMR, then you can combine it with a mitral clip. I could maybe describe one typical patient we treated with a combined approach. That was a patient with a very severe MR and a very large left ventricle of 72 millimeters and diastolic. And we were not able to clip this patient because the coaptation defect was so large and we were not able to grasp both leaflets. So we had to abandon the procedure. We came back with a Cardioband, but we knew already the heart was so huge, it was implanted outside the study, that we wouldn't be able to cope completely with this. So we implanted the Cardioband, ended up with an MR2, and then came back with a mitral clip because then we could grasp both leaflets and ended with a trace MR. That was a typical patient.
So thank you. Maybe one very brief remark, Ralph, very brief because we're running out of time.
I think it's a very interesting concept, and the University of Padua has introduced the LI index, which actually comes from surgery. This is leaflet to annulus index in the IP diameter or the septal-lateral diameter. And if you look at that, you can see that in certain patients you will not have enough leaflet tissue to coapt correctly. And to achieve this, you can, by purpose, if you measured that before, you can use annuloplasty, as George Nickney was describing it, to adapt the leaflets more, and then use any technique, leaflet technique, neocord or whatever, to then coapt the leaflets correctly. And this works wonderful.
Okay, so thank you very much. I think now we'll have to move on to the tricuspid domain. We open to the future. So, Karl-Heinz.
Yeah, thank you very much, Alec. It's a very new and very challenging field. And it's for the very first time, actually, that I think that at this meeting, we are going to talk about the option to use the Cardioband, which is the same band as has been introduced to you for the mitral valve that we are now using also for tricuspid. And based on also my personal experience, I think that we're all very excited that we have an option now to reproducibly treat patients with severe tricuspid regurgitation. And I think that reproducibility really makes the difference. I think there are different technologies out there. They can be used in individual cases, and good results have been reported. But at the end of the day, what we really need is a technology that can be safely and reproducibly being applied to our patients. So I'm very happy and glad to be part of this first symposium at the EuroPCR meeting. And I would like to introduce Georg Nickney again, and he will present us one of the cases that he did on the tricuspid side using the Cardioband. George, please.
Yeah, thank you very much. I'm going to stay here because the movie is on the computer. Tricuspid regurgitation is very frequent, and it drives also mortality, as we know in patients with heart failure or with concomitant MR. And most of the patients are not treated probably everybody of you has this picture in mind. In the United States, 1.6 million of patients with clinical relevant tricuspid regurgitation and 5,500 surgical cases only per year. So there is a tremendous unmet need for this type of patient and the need for a catheter-based approach. And the Cardioband had been reiterated a bit to fit also on the tricuspid side. So it's a small modification of the mitral system, and it's even easier to use. You need just a transvenous approach. It's a 24 French catheter, and then you are right away at the right atrium, and there you can start your procedure. And I would like to guide you through this. So I can explain it to you here that the patient is a 70 years old female patient with proximal atrial fibrillation and arterial hypertension. AFib is by the way, a very important pathology before the development of tricuspid regurgitation. And maybe I'll go back for a second. Patient underwent an aortic valve replacement 2016, mitral valve reconstruction at the same time, also 2016, and presented recurrently in our hospital and also in other hospitals with peripheral edema, fatigue, and dyspnea, New York Heart Free. And as you can see here, there is a tremendous TR. This is the right heart, this is the left heart. As you can easily depict, left ventricular ejection fraction is nice, 65%. Right ventricular function is reduced, TAPS are only 12 millimeter. Considering this TR, it's a severe RV dysfunction. And then you can see the inferior caval vein is dilated, and PISA is 0.8, vena contracta as 1.5, which makes it a massive TR. It's beyond a severe TR if you look at the gradings, regurgitant volume quite high. Not a lot of pulmonary hypertension. That would have been a contraindication in the trial. We have a cutoff of 60 millimeters of mercury, actually for most of the trials. So this is a summary of the patient history. No coronary artery disease, some postcapillary pulmonary hypertension, no severe pulmonary hypertension, as I stated. RV dilation, right, the left heart pretty okay after open heart surgery. So the heart team voted not again for a tricuspid open heart surgical approach. Mortality is as high as 20%, as you may know, for a isolated TR procedure on the open heart. And it voted for a catheter-based approach, and we enrolled this patient in the study with a Cardioband system. One of the major issues is, of course, that you have to have a dilation of the tricuspid, and the surgeons usually tackle the tricuspid if the diameter is more than 40 millimeters, and I think in that patient it was written on the page it was somewhere about 45 millimeters. You can do the procedure just in a cath lab. I prefer actually to do this procedure not in the hybrid room, because I would like to have the biplane situation, which eases the procedure quite a bit. Then you can have one plane perpendicular to the right coronary artery and one plane en face. And here you can see that there is a catheter. I may go back for a second. The movie is not very long, don't worry. Here you can see that we have always a catheter in the right coronary artery and also a wire, because it's a very important and very convenient landmark, which makes the procedure even easier because you know exactly where you are. It gives you really a nice orientation. And this is the en-face view. So here you would find the tricuspid valve. And here, this is the perpendicular view. This is the plane. Here is the right ventricle, and here is the right atrium. So fluoroscopy is also very, very important here, and you don't always have to rely completely on echo. So we have the sheath in the arterials, on the arterial side and also on the venous side, and then we get the TSS into the system. It's a 24 French guiding catheter. You don't have to go transeptal. This is already the GC. It's another catheter which is inserted into the sheath, and it harbors the implant, as you can see here. And then you start with the procedure. You have to start anterior, very close to the aortic root. And this is very important. I may stop here. And you have a complete workup up front. You do echo, of course. You got to be convinced that TR is severe and that clinical symptoms are related to TR. And then you have to do a CT scan. And the CT scan tells you vicinity of the right coronary artery to the hinge points of the tricuspid. And it also tells you the diameter, which band to choose. There are various sizes, 6 or 7 sizes available. In most cases, we need the largest size. Actually, we don't have large enough implants so far, but the company is working on this because it's a huge valve. And then you get this workup. You have a lab. You have this this iPad on the table. And this here is the aortic root. This comes all from the CT scan, and you have your projection, your predefined projection for the REO and for the LEO projection. This is the aortic root, and this mimics the right coronary artery. This yellow dots here, and this is the coronary sinus, and these blue dots resemble more or less the location where you should place your anchors. So it's pretty much planned, and it's a very calm procedure. Usually nothing happens during the procedure. And as you can see here, you gotta stay in this plane here. Once you dive into this direction, you can be more or less sure that you put an anchor in the leaflet. So you can nicely control the procedure also via fluoroscopy, of course, in combination with echocardiography. So next step is echocardiography, and you have learned already that you need different views. This is also a 3D volume, a flexi-slice volume that speeds up significantly the procedure. You can locate the catheter on the hinge point. This is very important, that you don't drive the anchors into the leaflet. And on the other hand, you can see on fluoroscopy that the anchor is not too close to the right coronary artery. You can also visualize the right coronary artery to some extent by echocardiography, but I would never rely on this. So here there is the first anchor, and you can see it is screwed in. Maybe I'll stop here for a second. It's screwed in here by Nikos Werner, who is always with me at the procedures. And here it comes out. There here it is easy to see. There is the aortic valve replacement. This is the aortic root, and this is a takeoff of the right coronary artery, and that's where you have to start the procedure. Usually there is the anterior lateral commissure, and then you have to place 3 anchors right here in that place because tension on the anchor seems to be very high at the beginning, at the start of the implant. You're getting close to the right coronary artery, but you can control this nicely, and you can change the trajectory of the catheter in order not to put an anchor into the right coronary artery. We had some anchors sitting in the right coronary artery, also in our institution. Nothing happened. One patient had a perforation of the right coronary artery, but it was easy to fix. But you should take care and should prevent this. This is another flexi-slice cut, and then you have to move around. And I think the next image is when all anchors are implanted. It takes a while, but you can learn quite a bit. We also did last week a procedure, and we implanted the whole fabric in 1 hour into the patient, and had some additional minutes before and after. You do a tuck test here, which means you are pulling on the system, and you can also witness this on echocardiography. You can visualize usually the anchors. That's what I like most. If I see the anchors on echocardiography in the myocardium, that gives you really a good feeling. And then you implant, as I said, the first 3 anchors really close to each other to have a lot of tension, to have a lot of force on on the tissue. And then you just negotiate around here step by step. There's an 8 millimeter distance between the anchors. We have different anchor lengths available, 5 and 8 millimeters, and if sometimes you are too close to the right coronary artery. Now all anchors are placed. You get rid of the GC. Of course, there's a wire sitting inside the cardioband, and you have to externalize this wire, and then you're coming back with another catheter. This catheter is introduced to the spool in the beginning at the start of the wire, and then you can turn the spool, and by this you can foreshorten the wire. Usually you can foreshorten the cardioband by 5 to 6 centimeters, between 4 and 5.5 centimeters. This is a baseline situation, no cinching, all anchors implanted. And then you have to do quite a bit of measurements. And here you can see the distance. It's 41 centimeters, 41 millimeters, and severe tricuspid regurgitation. Once all anchors are in place, but no cinching has taken place. And then you start the cinching process. You foreshorten up front by 2.5 centimeters. And here you can see the usual thing. We discussed that yesterday. Maybe I stop here for a second. You can see the right coronary artery. When you start the cinching, of course, you also foreshorten the right coronary artery. You can encounter some spasm here, and I will even show you some kinking later on. We have seen that in any of our patients, in the 10 patients we have treated so far, but we never encountered any issues with the patient. No troponin, no ECG change. There is slight troponin because you're implanting these anchors, but we never saw any clinical issues with that. And if you would look at patients after TR reconstruction with an open heart surgical approach, you would see exact the same thing. You can give them adenosine or nitroglycerin. This is the cinching here. You go on with the cinching process, and I think I will show you in a second the end point, or the last cinching point. This is, as if you recall, I will show you an echo later on. If you recall the massive TR up front, this is a very nice result. And here we foreshortened the distance from 41 to 23 millimeters. Maybe I can go back for a second that you can see this, that we are not talking about, that we are not bullshitting around, but this is real. I showed you before that we have 41 millimeters of distance here, and this is foreshortened to 23 millimeters. So
you just point to the cardioband. You see nicely
Yeah.
the cardioband there.
Yeah, exactly.
Yeah, go back.
Let's go back. This is the cardioband here. This is just a cut through the cardioband here and here on that side. And you can also see it here and here. So, and this is more or less the end of the procedure. After you have decided by echo that cinching is enough, that TR is more or less gone, or at least gone to moderate to a trivial level, then you stop the procedure. You just disconnect the system, and you are done. An H-shaped knot is enough to close the groin.
Perfect.
Also. So here you can see the kinking again of the right coronary artery, and you can see that the distance between the two between the anchors is by far reduced, and also the cinching of the whole annulus took place. So it's extremely effective, especially for the tricuspid side. But I can assure you, we have some analysis of the data, and Karl-Heinz Kuck will share this data with you, that the procedure is pretty efficient and so far also pretty safe. Thank you very much for your attention.
Thank you. Yeah. Now, Professor Kuck will give us the preliminary results.
Yeah, dear Alec, ladies and gentlemen, it's my real pleasure to share at this meeting the very initial results of the tricuspid repair study. And I'm doing this more or less on behalf of all the investigators that are sitting here on the panel. These are my disclosures. So as was already pointed out by Professor Nickenik, the incidence of mitral regurgitation that is treated today is rather low. So it's about 0.6%. This is, of course, data which are very difficult to prove. But as he mentioned, the overall number of people with significant TR is in the range of 1.6 million, and the number undergoing surgery is extremely low. And if surgery is done, then of course mostly it's done in combination with surgery for the mitral valve and not just for the tricuspid. It was also pointed out that TR, moderate to severe TR, has a significant prognostic impact. And as you can see here, the mortality of patients with moderate to severe TR independent from other functional or echocardiographic parameters or hemodynamic parameters is as high as 25% after the first year. And this is based on a large database, as you can see, with more than 5,000 patients that have been included into this database. So it's very, very clear that beyond mitral regurgitation, also tricuspid regurgitation has an independent prognostic implication for our patients. Now, this gives you some insight into the anatomy of the tricuspid valve and tricuspid ring. Now, in contrast to the mitral annulus, on the tricuspid side, there is more or less no annulus. There's no fibrous structure that you can identify, very much like on the mitral side. But what should be pointed out, and this is still a question of concern, that if you look to the septal leaflet over here, that there are some, of course, important structures. So on one side, you can look into the caval inferior vein with the Eustachian valve over here, and there's the ostium of the coronary sinus with the Thebesian valve over here. And then, of course, people are always afraid to move into this upper part, a mid portion of the septum and upper part of the septum. The mid portion of the septum over here is where the body of the AV node is located. It's not anteroseptal, that's the His. The His, the penetrating bundle, is sitting over here. The body of the AV node is sitting in the mid-septal portion, but away from the ostium of the coronary sinus. So even if you look to the roof of the coronary sinus, you still have a distance of almost 1 centimeter before you touch the body of the AV node. And I think this is still a learning that we are entering in to see where we can end at the septum with the Cardioband. And I personally believe, and we did a very nice case recently, that we can go as high as possible, much higher than probably has been done until now, so that we can cover the entire region, including major parts of the septum, so starting somewhere around here and then going all the way down and going around the septum until the mid-septal portion, where the septal leaflet is located. Now, the largest leaflet is the anterior leaflet, mostly followed by the posterior leaflet and then the septal leaflet. Of course, because the septal leaflet is attached to the septum, little enlargement at that site does occur. So most of the enlargement of the RV that leads to enlargement of the annulus is caused by the side of the anterior leaflet and the posterior leaflet. Now, the anterior leaflet is attached to the RV outflow tract, and the posterior leaflet is attached to the free wall. So these are the two dominant sites, if we talk about RV enlargement, that leads to an enlargement of the annulus site along the anterior leaflet and along the posterior leaflet, with little effect, of course, on the septal leaflet and the septal annulus. Now, the system that we are using that was so nicely and elegantly introduced by Professor Nikinik is the TR system, which more or less is a copy of the MR system, just the other way around. So we are just doing the opposite movements that you would do if you do an MR procedure. And you can see this is shown here in blue. So we start at this side and then we move all the way around. On the mitral side, we start anterolateral and then we move all the way around towards the septum. And again, it's very much the same movement. So it tells you, despite we don't have Dr. Latib talking about how much learning you have to do if you want to move into the tricuspid, but I'm sure next time we can copy what he said about the mitral. But of course, here we have the advantage that all of us started on the mitral side and now moved into the tricuspid side. So it's not only based on the experience from the clip, which is very helpful if you start on the mitral side, if you have clip experience. Now here, you simply continue with the experience on the mitral side. The only precautions were very nicely pointed out. You have to take care of the right coronary artery, which is very crucial, and of course of the AV node. So it's my real pleasure to summarize the first results of an ongoing study. So that study is still ongoing. It's not like what has been shown on the mitral that we finished the first-in-man trial. This is the CE-mark trial that is performed in Europe, testing the Cardioband device for severe tricuspid regurgitation. And very much like for mitral regurgitation, we are looking into patients with moderate to severe TR with an annular diameter of more than 40 millimeter. As you can see, with a pulmonary pressure below 60 millimeter mercury. Now again, I mean, if you have a right ventricle that can give you 60 millimeter mercury, it always tells me that you have a good right ventricle. So I'm more scared if the pressure is very low in a patient with a very poor RV function, because I think that these right ventricles fail much more often, or at least have the risk to fail, in contrast to a right ventricle that over time is able to provide a pulmonary hypertension. So I'm sure that we have to learn whether the 60 millimeter mercury is really the right exclusion criteria, or whether the 20 millimeter mercury in a poor RV function should be the exclusion criteria. That's something that at least I would challenge. If you have a right ventricle that gives you that pressure, it must be a good right ventricle. Otherwise, you can't get 60 millimeter or 70 millimeter mercury. So that's something that we all need to figure out, and then we are looking to patients with not too bad ejection fraction, and again, some kind of heart failure classification 2 to 4, and then the patient have to be on optimal medical treatment. Now, I just want to, with respect to exclusion criteria, mention that in general we do accept patients, and we have done it in patients already, I think many of us, that have a lead inside the RV. We just don't want to interfere, of course, with the system and the lead. We don't want to make the lead attached to the annulus. That's what we want to avoid. So we have to look where the lead is actually placed in a patient. And you know that sometimes these leads move into the commissures. And then, of course, you take the risk that you would fix that lead somewhere. So we want to make sure that we are not interfering with the lead. That's the critical issue. It's not the lead itself, it's the location of the lead that needs to be taken into consideration. It's very much like what we do also on the mitral. You want to be on the septal side of any lead that is in the right atrium if you go across the septum. So you don't want to take that lead inside of your transcatheter procedure. That is very important for any of these interventions. That's also true for the mitral clip. So that is something that needs to be determined by echocardiography before that the lead is not fixed towards the commissures, and that would give us some trouble if you do the procedure. Now we have primary and secondary endpoints for this trial. The primary safety endpoint is shown here, which is a combined endpoint of death, myocardial infarct, tamponade, surgery, which is device-related, and stroke. And then very much is also for the mitral study, we have technical endpoints or procedural endpoints, whatever you call it, which is successful application of the system, deployment of the system. And then, of course, we are looking again to a endpoint, which is an anatomical endpoint, which is a reduction of the annular diameter. And then we are looking into functional and hemodynamic tests, which are secondary endpoints, which are listed here. And these also includes, of course, pro-BNP. Again, it's very difficult to define what is really the best outcome endpoint in patients with severe tricuspid regurgitation. So this is a long list of several echocardiographic, functional, and blood level endpoints here that we are looking in. And still we have to learn what is the best outcome endpoint for this patient population. Now these are the centers. You see all these people sitting here on the panel that are part of the study. And this is the preliminary results that I can share with you. These are data on 20 patients. The overall number now is 25. It's a typical patient population at an age of 75 years. As you can see, most of these patients are of female gender. Most of them have pulmonary hypertension. The overall ejection fraction of the LV is quite good as compared to the mitral study. But then you can see that these patients have quite a lot of comorbidities. And I also would like to point out that 61% of the people have atrial fibrillation. Now, it was pointed out already by Professor Nikinek that atrial fibrillation does play an important role also, of course, for mitral regurgitation. We know that mitral regurgitation can be caused only by atrial fibrillation, which leads to dilatation of the ring. And of course, because there is no ring on the right side, mitral atrial fibrillation may play a more important role even in the dilatation of the ring. So you may have patients with a quite good RV function, large right atrium, and dilatation due to atrial fibrillation. So that's why I'm saying you should be an electrophysiologist to really take care of these patients. So atrial fibrillation treatment may definitely affect also the effect on the TR if you take these patients back into sinus rhythm. So that's why I believe, and that's something that we have to improve, that we should collect data on the underlying rhythm over time. If the rhythm change, it may have by itself some impact on TR and also on MR. So this is a significant and important information that is shown here. Now it looks very much, and I think we can discuss that during the discussion, it looks very much like when we started on the MR side. I think you remember that Francesco showed that in the initial phase of the MR study, we had 2 deaths. Now, one case was also intracranial bleeding. It was a patient with triple therapy at the very initial experience. And then you see another case, which happened over time with cardiac tamponade, which was a very complex follow-up of these patients, but he died weeks after the procedure, not due to the procedure. But as you can see, and I would like to stress that point, if you consider the very bad demographics of these patients with a lot of comorbidities, very sick patients, then I think there's one important statement that we can make, that overall for this patient population, the procedure is very safe. There were no other complications as listed here in the initial study. Now the device really did what was shown in the recorded case that you just saw. It is reducing the annular diameter in a similar fashion like on the left side. So this is around 30% of annular reduction. And as you can see here, there's a variety of annular diameter, 40 up to 55. And the impact on annular reduction is quite impressive in all of these patients. On average, it goes down from 46 to 33 millimeters, which is something that I think that all of us who are doing multiple procedures with different technologies can point out that this cannot be done with any other device at this point in time. And it's also important to know this, that you have to achieve such a significant reduction of the annulus to see any effect on MR or, as in this study, on TR. So with just a reduction of 1 centimeter of the annular diameter, I can tell you, you will not see any significant effect on MR or TR. So this is an important learning from the MR study, that the reduction has to be in the range, and that was pointed out, between 3.5 up to 5.5 centimeters to see an effect on functional regurgitation. So if people talk about 1 centimeter reduction, you know, it's nice to have, but it's definitely not good enough. And this is what was so exciting to me, that we can really achieve reproducibly this significant reduction. This is the prerequisite. It doesn't necessarily mean that you eliminate MR or TR in any patient. But if you cannot achieve it, you know that you will not impact TR or even MR in any of these guys. Now, as was pointed out already before, the numbers are small, so don't overestimate these numbers. We are in an early learning phase, and this is, again, data that are controlled by the core lab, so the numbers are a bit behind the actual numbers for analysis, but it shows you that the data are going in the right direction. There is a significant reduction of ARO-A, and not yet significant, but there is reduction of the vena contracta on the right side too. So again, the number cannot be significant. And again, I think that's also important to mention. Some of these early cases that we started were terrible cases. You know, they had gaps between the leaflets of 1.5 or even more centimeters. So this is not the case you really want to do. But since there's no other option to these patients, you offer it to the patient. But I hope at one point in time we can treat them earlier. Don't wait until the annulus is so much dilated that we have to do it. And then, of course, you have to accept that some of these patients remain over with some gaps, which, and that is something that maybe Dr. van Barleben can comment, you see further improvement over time in these patients. So this also is associated with improvement, as you can see here, in functional quality of life parameters, but also in the functional class. And this is quite impressive, and I hope very much that we can sustain these results. Again, this is small numbers, but you see how much these guys improve. Some, of course, and we also need to understand why they don't improve. Again, it's early learning, but the initial experience is at least encouraging. It's not yet the final answer, but it's encouraging. So in conclusion, Mr. Chairman, ladies and gentlemen, the early experience of the Cardioband in patients with severe tricuspid regurgitation shows, as for the mitral side, that the Cardioband can be implanted in a safe and feasible fashion in all of these patients. There is significant endo reduction in a way that is extremely hopeful for the future, that it really leads to a significant reduction in TR, as is shown in this initial experience. The substantial reduction in TR seen at 30 days could be demonstrated by core lab data, despite some of these patients had terrible TRs. So this significant reduction is clinically meaningful. There's no question with functional improvement of the patient. Of course, we have to continue to develop the best clinical endpoints for studies that we have to plan, of hopefully also randomized studies that we have to plan, or we have to take the right decisions. And we'll continue the study, and hopefully within the next 12 months we can provide you with the same set of data, but with more patients that we have obtained, and answer some of the very important questions: who are the best patients to be treated with the Cardioband. Thank you. We brought together here probably the most experienced investigators at this point in time for tricuspid regurgitation using the Cardioband. Now, before we go, what is the perfect case? Very much like what Alec was addressing, I really would like, again, to see what is the difference. And I would like to address this for the safety arguments. So I would like to know from everybody, you know, whether the safety of the procedure on the right side, based on this very initial experience, is somewhat different than if we do the same procedure on the left side. I just can tell you, whenever I talk about it, everybody jumps up and talks about the right coronary artery. George was showing some potential implications that the procedure may have on the right coronary artery. And then, of course, everybody jumps up and talks about the AV node, and that we have to avoid the AV node. And it was interesting for me yesterday, maybe Francesca, we can start with you, because you still continue to be a surgeon at this point in time. And somebody said, I didn't know whether it was you or was it Mike Mack, who said, if I put a needle in the AV node, it causes AV block. That study I would love to see. So maybe you may comment on this. How sensitive is really the AV node, and how aggressive should we be based on your surgical experience to move upwards at the septum and to have a more positive effect on annulus cinching without risking to kill the AV node?
So
Good question.
It's a good question. I wonder if...
You ask this poor guy who cannot even see the left ventricle.
No,
If he can
again,
see
I give him some more time to think about the answer.
No,
You know,
let me-
what I learned yesterday, it was also funny for me, and George made this comment. Yesterday when we talked about the right coronary artery, it was Mike Mack, he is a surgeon, a very famous surgeon. He said, yeah, we have the same experience in surgery. I said, you don't even see the right coronary artery, so how do you know that you have the same experience? I mean, I've never seen a surgeon doing such a procedure, doing an angiogram of the right coronary artery, but he said immediately, oh, we have the same experience. So we have someone who can do both percutaneous and surgical procedures. So let's learn from Francesco. How much are you afraid? How good are the data really to say where we have to
So-
put the anchor, where we shouldn't put the anchor?
So let me, can we go one step behind? Because I see terror in the eyes of the people here. Because, you know, no one in this room has ever done a cardioband mitral. Now we're talking about very specific tricuspid.
So let's
debates.
ask, did somebody do, let's be very broad, did somebody do an intervention, a percutaneous intervention on the tricuspid side in this room? Whatever intervention it was? Okay,
Yes,
so there are a few
Jörg, no.
people.
Two hands,
So we know Latip, so
We have Murat.
what kind of
Murat.
intervention? A clip.
Yes, okay.
Oh yeah, both.
Couple of
Okay.
clips.
Oh yeah, I did.
So,
Okay,
you know,
so very few.
So I would like to go just one step behind. Compared to other procedures, this is one of those procedures where we can get a lot of information from surgery. Not everything, but we can still. It's very close to surgery. So as much as the tricuspid valve is concerned, all tricuspid rings cover the circumference of the annulus also in the region of the septum. So they go 2 to 3 centimeters in the direction of the AV node. So we in surgery avoid putting sutures just from the septo-anterior commissure 1 centimeter towards the coronary sinus. And in my practice, I do this always on beating heart, because if I get some electrical feedback, I will stop. I will not go in that direction.
Oh, you want to do it from here?
So, and so I think it is a very important point that if we want to improve our outcomes, we need to fix the cardioband like we do for the mitral on the 2 trigones. We need to do the same things for the tricuspid. We have to get to reach the septum, so go beyond the coronary sinus. This will be a learning that we are learning now.
But I think this is too much of a detail right now. I mean, we have to think about feasibility. And so far, sorry, Francesco, to interrupt you. So far, we have seen if the patient is not completely off the target, has a vena contracta of 2 centimeters, we can fix the TR even with this device. This is the image of the patient I have shown you before. It's before the procedure and after the procedure, and TR is completely gone in this patient, even without.
Can I say
troubling
tell you
the AV
something
node.
more to relax the audience as well, because you know Cardioband is new and Cardioband tricuspid even more new. So I tell you what was my experience going from the left to the right for Cardioband. So I did the first in man Cardioband tricuspid after some experience on the mitral. It took me 2 hours. You know how much it took for me the first mitral clip? 4 hours and no results. So the message here is that it is much easier to reproduce what we do on the left side, on the right with Cardioband than with other devices. I'm not comparing to others, but really, it is feasible. We have been demonstrating this. I mean, at the end, it's been introduced maybe almost faster than the early phase of mitral Cardioband. So it is still early. We should not say it is the solution for everything, but you know, the initial steps I think are very promising.
Okay, but if I may just point, because we discussed a lot about this right coronary stuff, but for the audience who has no experience at all, can you put it in context? Because you said that you've done more than 10 now. It doesn't cause a long-lasting problem. doesn't lead to poor outcomes. Can you just explain?
Yeah, I mean, Karl-Heinz just showed us the safety data. We had we had 2 patients in which we had bad experience up front, very early experience in 2 patients. And ever since that we didn't have a real safety issue so far. So to this answer, to this question, I think it is as safe as it is on the left side. And I mean, on the left side, you also have to cope with the circumflex artery, which can be also nearby. But you have echo and you have fluoro. You can go around the right coronary artery, and we have even witnessed yesterday a case from Mainz, and we also have a case in Bonn in which we crossed the right coronary artery, which we went up to the wall of the right atrium, if you will. And this is also doable. You can completely control it. You don't have to rush through the procedure. So I think it's safe, and the right coronary artery is an issue you can deal with.
I think, if we discussed before the difference between surgery and the Cardioband in treating patients with severe MR and TR. And I think one of the major differences that, of course, we are mentioning all the time but did not specifically address is the fact of safety. If you would treat such a patient population with such a poor LV function and these comorbidities, you would expect to have a higher peri-procedural mortality, as has been shown also in the large series of mitral patients. And I think this is very much what we all appreciate, that the procedure can be done step by step, very carefully, very slowly, very, very, very similar like also the mitral clip. So I think that we probably should all shortly comment on this, that we all have a very good feeling that we can treat these very sick patients with the Cardioband without being at risk that the patient doesn't survive the intervention.
Yeah, I think it has to be one more stress that this population in surgical practice has been treated.
Yeah.
50% mortality. I mean, redo surgery in a patient with isolated tricuspid insufficiency has a 50% mortality.
But you do agree also is because poor patient selection and too late an intervention.
Obviously, this is an important point. Obviously, I love to treat the tricuspid. I hope I will not do it so often because I think it is a missing opportunity. Once we treat patients with isolated tricuspid, there's been a mistake in the timing of the previous interventions. Tricuspid comes last, so we should really implant Cardioband and mitral very early, so we don't have to learn how to implant in tricuspid.
And just before finishing, because while you were speaking, I think Francesco was not listening. He was telling me, well, maybe if you have a severe TR, after implanting the Cardioband, you can put a valve in. Were you serious?
Well, this is just so we have been discussing many times whether after Cardioband, mitral, you may have a support for a transcatheter mitral implantation. Obviously, yes, but not with a sapien, not as a Vahanian ring, because it's an incomplete ring. We know that incomplete rings are not good support for a mitral Vahanian ring because of the risk of LVOT obstruction. The good news that on the right side there is no LVOT. There is an infundibulum, so there is space. So in principle, I would expect that patients who fail angioplasty may become candidate for Vahanian ring.
Wow, for next year. Huh?
Maybe before.
So there's a lot of things to do, to test the AV node, to test the complete valve in an incomplete ring. So we have enough to do. So I think, ladies and gentlemen, is there any burning question from the audience side that we need to discuss that we didn't cover? If this is not the case, I just would really like to make a very short summary. I think that the session has shown that the Cardioband is a very important addendum to intervention technologies for both the mitral and also the tricuspid valve. The mitral is on a very advanced stage of experience with proof of concept to show that it can safely be done, that it leads to reproducible reduction of annular diameters and thereby affects significantly also mitral regurgitation. And we are just in the process to copy these results for the tricuspid side, which I believe is even more important, because to do a clip procedure on the right side is much more challenging because the device has not been built for the right side than the Cardioband, which actually is a copy of the left-sided procedure. So I'm really looking forward for the future. The future is quite interesting, and I couldn't agree more with Francesco that we are copying a surgical procedure without surgery. So thank you very much for all of you for coming to this very interesting session. I'm sure that you will hear more about these interesting technologies over the next couple of months. Thank you for coming, and enjoy the rest of the meeting.